Okay, I think time is up. So hello, good morning and good evenings. I'm Dr. Pang Yun Chou. We are so happy. Yes, I saw a lot of our friends already online with us in advance, probably 10 or 20 minutes ago, because today we have very special teachers online with us. So we are so honored to invite Professor Ben Rabin Lai to give us a special lecture. Professor Rabin Lai currently is the chief in the divisions of plastic reconstructive surgery in Kaohsiung Chang Memorial Hospital. He has dedicated himself in treating the patients with congenital craniofacial anomaly for decades and advanced his surgical practice with innovative 3D printing technology. Besides, Professor Lai has collaborated with numerous neighbor countries in the missions. They're working together, learning together, and sharing together, such as with the Cambodia, Mongolia, Vietnam, and so on. The topic today, Professor Lai will present is alveolar bone graft in Cleft patients, a practical knowledge, either in Taiwan or in where our friends come from. Let's welcome Professor Lai. Professor Lai, please.
Thank you, Wang Yun. Well, you introduced me too nice. Well, everything I can do now is all comes from my mentor, Dr. Nordov, and also from Professor Law and even Philip K.T. Chang. So today, I like to share my experience and the knowledge about how to repair an alveolar cleft. I know all the participants are expert in this field already. So the talk about tonight, I will just shortly talking about the histological perspective. I will focus on some debate issued on this topic. Let's go on. Well, alveolar cleft is not so obvious like a cleft lip or palate. So it's not really a popular operation compared to the lip repair or palate repair. So it haven't been common as, the first described procedure to operate the alveolar cleft is just only in 1901 by Dr. Alveolar. He used the pedicle flap. Unbelievable, his the little finger to feel the alveolar cleft. And so only to the 1950s, advocated by some doctors, so such as the Exhausen, established the concept of how to manage the maxilla arch and preserving the dentition. And then Schmidt did the first successful alveolar bone grafting using the iliac bone graft. Why we have to do the alveolar bone grafting? Many years ago, Dr. Antonio Wolff wrote in the textbook, tell us the alveolar bone grafting can provide the stability of the maxilla, permit the tooth erupted, and obliterate the fistula, and can improve the cosmetic effect and even improve the speech. Well, in this year, we find some the indication actually changed. Of course, for the bilateral cleft, the premaxilla actually is mobile. So the alveolar bone grafting can stabilize the premaxilla for the bilateral cleft. But for the unilateral cleft, actually the arch form is stable already. And elimination of the oral nasal fistula can improve the oral hygiene, is true. And very important, we can use the bone grafting to support the teeth close to the cleft and facilitate the tooth movement into the cleft by the orthodontic management. And the other thing is the alveolar bone grafting can level the nasolalar base. So he will really improve the looking of the nose after abundant bone grafting to the paranasal area. There is something more. How about the orthodontic surgery? Is it really necessary to have bone grafting before the orthodontic surgery? In my opinion, and some doctor, I think Professor Law or Philip Chang, they also agree that if we can, we should have our bone grafting before the orthodontic surgery. But for the unilateral cleft, the separated leg for one segment can be moved separately. So actually, we don't really need the pre-OGS our bone grafting for the unilateral cleft. And even we can do our bone grafting simultaneously with the OGS. For bilateral cleft, I think that's another story. Without the previous successful bone grafting, the blood supply of the premaxilla may be compromised if we degrowth the premaxilla to do the osteotomy and do the transverse osteotomy of the whole maxilla segment. Of course, from the textbook, from some seniors' opinion, they can do the OGS transverse the one osteotomy on a bilateral cleft without the bone graft. But I think it should be very careful to preserve the soft tissue on the premaxilla, or it will cause problem. I have terrible experience personally. So up to now, I still think for the bilateral case, we should design the OGS very carefully if the patient has no successful alveolar bone grafting, or we should do the alveolar bone grafting before the OGS. And if you review the literature, you will see a lot of debate about the timing of the alveolar bone grafting. We all know what is the primary bone grafting, secondary, or even somebody mentioned the so-called tertiary bone grafting. Primary alveolar bone grafting has been popular for 1 or 2 decades, but since 1970s, it won't be a very common procedure then. That's because Dr. Pigwell, they have a study tell people that does primary bone grafting have some restriction effect on the midface. So since then, the secondary alveolar bone grafting is getting more popular, and now even very few people do the primary alveolar bone grafting, and also because there are donor side problem. For the very young kids, the primary alveolar bone grafting always choose the rib as the donor site. And the rib graft actually is not so ideal for the alveolar bone grafting. In 2005, the American Society of Cleft and Palate, they conduct a survey. They found 90% of the plastic surgeons in United States, they do the secondary alveolar bone graft. Just a few doctor center insist the primary alveolar bone grafting. And at the same year, Kaohsiung Chang published a paper in the PIS talking about the restriction of the secondary alveolar bone grafting. We found there is no significance between the graft or a graft patient or non-graft patient. So it also an evidence to prove that the secondary alveolar bone grafting, when we did do it at the age after 7 years, will not cause any mid-phase growth problem. And how about the primary GPP? It's a boneless primary bone grafting technique. And this technique relies on the osteoinduction capability of the periosteum. Since 1967, some paper talk about this. Allow me to use the study conducted in Linkou Chang'en, published in 2016. And the conclusion that they found the primary GPP can achieve 70% success, but the bone is less than the secondary alveolar bone grafting. For me, I have done some few cases in my hospital, because even we did the passive NAM, it's very difficult to narrow these kinds of a wide cleft. So if the cleft is still wide, I cannot do the GPP at the time of lip repair. Of course, after the lip repair, when we do the palatoplasty, the cleft always narrowed. So there is a chance to do the GPP at the same time with the palatoplasty. But it's still not a very common, usual to have a narrow cleft, narrow enough to do the GPP. How about after the lip and palate repair, the cleft always become very narrow 2 or 3 years later. But to do another surgery at a very young age, I think it's not really worthwhile. So I don't want to do many primary GPP. And how about the timing of the secondary alveolar bone grafting? Should we do it according to the chronologic time or the dental age? And actually, the presence or the position of the lateral incisor actually is an important consider point. And the degree of rotation, angulation, size, and occlusion, and even the need for some other procedure like the treatment of VPI. And the social indication is also important consideration when we decide the timing of the secondary alveolar bone grafting. Actually, the conclusion is a kind of a compromise or balance between all these considerations. Up to now, the secondary alveolar bone grafting is the most common timing. This means we will do the alveolar bone grafting at the age between 7 to 12 years old. That is also my most common timing to do the alveolar bone grafting. Next, we will talk about the type of the feeding material. Up to now, I think people still think the autogenous bone graft is the gold standard, especially the cancerous bone graft from the iliac crest. Sometimes we can use some bone block from the Cavarian bone, but the bone block in the alveolar bone grafting, sometimes it has the problem such as the shape, how to fit the cleft, or the fixation of the bone block will cause some other problem. So I think the cancerous bone graft is still the gold standard if you want to use the autogenous bone graft. But more and more people, the more and more study, they found the allogenous bone graft, especially the demineralized bone matrix, has a similar effect on the alveolar bone grafting compared to the autogenous bone graft. Especially when you put some recombinant human BMP2 protein with the EBM, the results is quite convincing. I think the only problem is the cost. If the cost can be cheaper or acceptable, I think maybe it's a good alternative to do the alveolar bone grafting without the donor site mobility. This is the table I catch it from the paper. They describe the advantage and the disadvantage of the material. I think everybody agree that we can get the iliac crest bone graft from the iliac crest. I think it's still the best side. We can get a very abundant volume, and if we do that carefully, I think the donor site mobility is not so severe. My personal experience up to now only have one donor site wound infection in the past 20-something years. So I think the wound is okay. The scar is also acceptable. Of course, they will cause the kids some ambulation pain for a couple weeks. But up to now, I didn't find any permanent ambulation problem after the bone harvesting. The rib is also
it's okay.
The rib is also a good place to get the bone, but the quality of the bone is not so good. Mandible is also a good donor site, but the amount is limited. Now, in some cases, I use the mandible as the donor site. I can harvest about 1 cc from the parasymphysis through a small window on the outer cortex. And If the bottom is not enough, I will mix this cancerous bone with some bone substitute. And in some cases, I found the bone grafting is survived, but the bone volume seems not so thick enough. We will see. And the Cavarian bone graft up to now is very, very rare to do this. Of course, we can get a very good quality bone graft, but the problem is the fixation. In Taiwan, we up to now, maybe I'm wrong. We don't have the DBM. I don't know if others know that. I don't have that kinds of experience, even the recombinant BMP2. But from the literature review, it seems quite convincing. So we will see. So yeah, there are many papers talking about this. So I think that's the future we should look up. Another issue people will think is the how to prepare the local environment for successful alveolar bone grafting. And one is the pre-ABG orthodontic management. And I will be very glad to cite this paper published in PR in some journal, and it comes from our Lincoln Gung, Dr. Zhang Chenxin. He is still online, right? Yeah, you a good job. Tell us there is no there's a superior bone volume when the patient has pre-ABG orthodontic management. So now it's almost routine if the patient has some problem like rotate or angulation, lateral central incisor, or cover the teeth, cover the alveolar cleft, and the orthodontic will help us to align the teeth and somehow can facilitate our operation. So the following, I will talk about some alveolar bone grafting technique. Well, I have to say that I have to thank Dr. Philip Chang. He told me how to do the alveolar bone grafting when he came back from Canada. I was the resident. He told me how to do that. So I think I still use that technique. He wrote it in a textbook and called it the Chang technique. So the following my description, mostly based on this technique. The first case, I will show you the unilateral cleft. It's a big hole, and even have the big fistula on the palatal side. So we will design a wrap to open the alveolar cleft. Very important thing is that this oblique cutting line, I will cut it in between the gingiva cover the molar. So if we want to advance this gingiva periosteum flap, still have some gingiva cover the molar and even the premolar area. And I will dissect even on the widely on the non-cleft side. It will facilitate, we elevate the breadth and to see the bone structure well. And this technique emphasizes the palatal dissection a lot. In original Posnick technique, it dissects very wide palatal side. I think right now we did a just limited palatal dissection only because now our palatoplasty has been done very well. So the palatal fistula sometimes is not so long or even no palatal fistula. So we don't need to dissect very wide palatal side. So when elevate this mucoperiosteum flap or gingival periosteum flap, we can see the fistula well. And this flap will go to the nasal side, and this flap also to the nasal side from the palatal after we separate the adhesion between the palatal mucosa and nasal mucosa. And then we have to repair this defect, use this, it's not only mucosa, actually it's a periosteum, mucoperiosteum flap on the nasal side. So we have to repair from the palatal side to the nostril furrow. And I think it's a good thing if we can refract the periosteum and repair them together. It also have the potential to regenerate bone. I think the most tricky part is here. If we dissect the very extensively, that means we have to separate the palatal mucosa from the nasal mucosa for a long distance. And sometimes it will cause problem. If we break it, it's very difficult to close it again. So later I will show you another case. Now I believe Professor Low's technique. In his paper, he harvests a fascia graft and put it here to facilitate the closure. I think no matter here or the nasal side, I think it's a good idea to operate all the leaking, and they can secure the closure and prevent the infection. Then we can insert all the cancerous bone into the cleft. And usually I will do that even under the paranasal area if I have enough cancerous bone graft. I know Bangyun has a paper used the 3D CT to calculate the defect and to estimate the volume we need. About only 1 point something cc. But usually I will use as this 3 cc, 3 milliliter cancerous bone to fill up all the defect and even the paranasal area. Then we close the wound. Usually I will close the fistula first, and then I will try to advance this flap to cover all the defect. If not, we have to advance from the lateral. So we have to do some periosteum scoring. Scoring, then we can move it without tension. This repair must be very careful, especially here. It's like a 4 flap suture together. Now I try to not really close 4 flap. I will repair this first, and maybe switch a little bit, prevent a real closed wound here. Okay, this is the result from the palatal side view. And you see, if we can do the good bone grafting over the paranasal area, the alar base will be level. The nose will look better. From here to here, actually no rhinoplasty. Okay, I will show you a video. I always inject a lot. If I can, I will ask the dentist help us to remove the before the alveolar bone graft. But if not, we can do that during the operation. But must be careful. We have to sure we can close the wound. And I will elevate the graft along the fistula. I usually do the elevation from the buccal side first. Of course, Philip Chang or Posnick, they would like to do the palatal side dissection first. But I think it's all right. Yeah, if we have enough exposure, it's easy to dissect the alveolar cleft. Now I'm doing the palatal side dissection. The reason to do the palatal side dissection is to prevent the damage to the nasal floor. Sorry, to prevent the damage to the palatal side. I think it's good. If we make a hole on the palatal side, it's very difficult to close it unless we do the whole palatal dissection to have a palatal cleft, or it's very difficult to close the defect on the palatal side. Okay, so now we start to close the nasal floor. Make sure we close everywhere. And then the palatal side. For this case, I think it's okay. So I don't use the facial graft to help secure the palatal repair. Then we will put the cancerous bone graft inside the defect. So Bangyun, actually, we need a lot of bone graft. I usually suture the buccal side first and start from the fistula. Okay. Okay, so we use the CT scan to evaluate the result. Yep. You can see the bone grafting here. Yun, do we have enough time?
Yeah, sure. Yeah, we can go on.
Okay. So the next web will show the technique how to do the bilateral cleft. I know lots of doctors, even Professor Low or Philip, they will do the bilateral cleft at the same time. In my mind, actually, I will see if I can do that. I will do that at the same time. I mean the bilateral cleft. But for me, I will see the condition. I will show you by this case. This is a bilateral. The cleft is acceptable, but you can see here the premaxilla actually is immobile. The palatal side mucosa does not attach to the palatal side. So it's a complete fistula here. For me, I would think it's difficult or even impossible to do the bilateral alveolar bone grafting at the same time. Because if I dissect these both sides and even the buccal side, the blood supply of the premaxilla, and especially this area, will be a problem. I know in even Professor Low's paper, he did he say in his picture, he said just a minimal dissection here. And I think it's quite dangerous. So for this case, I decide to do the one side alveolar bone graft only. And then I would do that a couple of months later, the other side a couple of months later. The technique is almost the same. The only difference is here, or the dissection over the premaxilla. Usually, we will be a little bit conservative compared to the unilateral. Otherwise, the dissection is almost the same. For the bilateral case, the palatal side dissection, in my mind, is very difficult. So I will dissect over the weight from the anterior to posterior, the margin of the posterior margin of the fistula. Preserve the other side as the pedicle of this the palatal mucosa of the premaxilla. And now I found there is a hole goes through the nasal side. and I think I have a problem. It's very difficult to close this this hole. So do you see this? No. I will trim some soft tissue and close the nasal floor defect first. And the palatal side, I use a small piece of fascia graft to cover the apex area. And then close the from the posterior to the anterior. So the fascia will operate the defect over the apex area. Then we can insert the cancerous bone. And before I start to insert the cancerous bone, sometimes I will insert the gauge from the nose to protect the nasal side suture. Then close the wound. Okay, so that's my technique, and I always use this method to do the unilateral and the bilateral alveolar bone grafting. So up to now, people satisfied or any problem? Any comment?
Professor Lai, you have a further slide to share, right?
Yep.
Yeah, you can go
Okay,
on,
we
no
can
problem.
go through it. Okay.
Yes, yeah.
Okay. Usually we can have a successful alveolar bone grafting. In my early career, actually, I have very terrible time. The successful rate of alveolar bone grafting on my first year is about 70 to 80% only. In that year, I have to do about 40 cases in a summer. And that means I have to face a lot of infection, failure, and a foul smell in my clinic. So it's really terrible. I even invited Dr. Philip Chang, or even a professor from the Chang University to supervise my technique. And actually, Philip said he couldn't see any technical failure. but I don't know why. The successful rate is very low. Finally, I found the pre-ABG orthodontics really help, and especially it can help to clean the mouth, to get the patient have a better oral hygiene before the surgery. And then in my late operation, the successful rate raised to 90%. And another thing is the second decade of my alveolar bone grafting, I have do it on my own patient. My own patient means I did the lip and the palate repair by my hand. And my palatoplasty, I emphasize I will close the palatal mucosa even up to very anteriorly to back to the teeth. So usually I will have a very small palatal fistula when I do the alveolar bone grafting. And second issue is that I use the vomer flap to repair the nasal side when I do the palatoplasty. And I found in many cases there is bone bridge between the alveolar palatal cleft. So that means when I do the alveolar bone grafting on a complete cleft lip and palate patient, but I still have palatal bone continuity. So it almost like I do the alveolar bone grafting on the cleft lip patient. So the dissection over the palatal side become very easy. I think it might be an important factor to have a greater successful alveolar bone grafting in my career. But I still have some difficult case I would like to show you, like this one. You see a very wide cleft, very, very wide. I think it's difficult to do the alveolar bone grafting. I mean, get a success. You see a very big hole on the palatal side. I have to say this is not my primary palatoplasty case. So I think it's difficult to do the palatal repair. So my strategy changed to I would open one side cleft, and I use the tongue flap to close this defect. And you see the tongue flap first go to the right side cleft. And then when I did the division, the pedicle will go to the left side alveolar cleft. So I close the both side alveolar cleft, I mean the fistula, by the tongue flap. And then I open it, do the alveolar bone grafting with the cancerous bone at the same time bilaterally. So this is the apical view just after the bone grafting. 2 years later, the orthodontic aligned it, but the right side seems some resorption. And this is 5 years later. And you see after the eruption of the canine, the orthodontic can align it. He's at 15 years old now, and she has some mid-face retrusion, but you can see the alignment of the piece is quite acceptable, and I really close the fistula and have a acceptable bone graft at both sides. So this I use the tongue prep beforehand to close the palatal defect and the fistula first, and then do the alveolar bone grafting at the same time. So you can see that the defect and the bone grafting. And how about this case? Well, this kid's quite interesting. He was born in the Nicaragua, okay, Dominica, or somewhere in the middle America. His father is a Taiwanese, but the mother is the local people. And he was treated by the American doctor on a boat, on a ship, a hospital ship. And then the father brought them together back to Taiwan at his age of 11. And you can see these kinds of dental alignment and very protrude premaxilla and the low set big hole here. When he smile, it's quite not so good. But you look at the lateral view, the facial profile seems okay. So what we can do to close this alveolar cleft? Should we set back the premaxilla and reduce the size of the alveolar cleft? It will cause the midface become retruded. So you can see that X-ray, the very protrude and the low set premaxilla. This is the CT scan. So we designed a posterior segmental osteotomy and advance this 2 segments forward by the distraction to meet the premaxilla. Of course, at the same time, we expand these 2 segments. So this is the operation. I did the posterior osteotomy and insert a plate with the wire comes out from the nose, the nasal floor, the ala, and set up the distraction. So by distraction, we move the posterior segment forward to meet the premaxilla. So this is the time we remove the distraction. So they come together, and when I remove the extractor, I do I did one side of the bone grafting. So 6 months later, you can see the bone union on this side. So the premaxilla becomes stable. So I have to do just only the other side of the bone grafting. And the patient still have a good facial profile. So I did another side bone grafting. Up to now, it's just after a couple months later only. I mean, you can see that the alignment is good and the facial profile is preserved. So I just show you 2 difficult cases, and I think by this special way, we can solve this problem. Maybe some doctors will have another opinion. I would like to listen. And what is next to the alveolar bone grafting? If we have a successful alveolar bone grafting, the orthodontic doctor can align the dentition, and they can expand the dental arch. We also can do the distraction to correct the mid-face retrusion if we have a successful alveolar bone grafting. And of course, when they grow up, we can do the orthodontic surgery if necessary, and with a whole dental arch. And the other thing is, how about insert the implant into the alveolar cleft? In the past, the orthodontic doctor, they like to align the canine into the alveolar cleft. And because many children, they don't have the lateral incisor. So the canine will become the lateral incisor, or they will have 3 incisors and make the dental midline become deviated. So now we can, if we can do the dental implant on the inside the alveolar cleft, we can have 4 lateral incisors, and then they will really make a good looking of the upper teeth. I think so. So this will be the next step we have to do. Up to now, some study has been published about this. I think there will be another step we will do. Okay, thank you for your listening. It's all my presentation, and welcome to Kaohsiung. Thank you.
Okay, thank you, Professor Lai. Thank you for your wonderful and really very excellent presentation. You can see a lot of the question in the query for your talk. I will reserve my question for you privately because you have too much questions for you now. So the first question is that, yeah, thank you, Professor Lai, for your great talk. I check. Okay. Do you experience to use the bone block, combine cortical bone and the cancers bone for big cleft? Yes.
Yes. But basically, there's only late secondary alveolar bone grafting. That means on the some adult patient or during the orthodontic surgery, because for the bone block, we need to fix it. You need a screw or you need a mini plate. For the young kids, I think maybe it's too much. So I preserve that for the older patient. For the young kids with a very wide cleft, I think we have some other way. Like Dr. Philip Chang's and Alveolar's interdental distraction. I think it's a good way to narrow a very wide alveolar cleft if we need.
Okay, and the next question is what fascia do you use to put on the plateau side?
Oh, there will be a scarpa fascia. Yeah, when we harvest the cancerous bone from the iliac crest, we can harvest a small piece of scarpa fascia from the same wound.
Okay, and according to your presentation, you say you harvest the bone from the parasymphysis. So where is the safe zone to obtain the bone graft?
I think just anterior to the filament. And there is, I just opened a very small window, like less than 1 centimeter, maybe just 7 7 mm to harvest it.
Okay. Based on your video in unilateral cleft, do you put the teeth back after suturing the wound?
No, that's all deciduous tooth, not the permanent, not a permanent tooth.
And
Oh, I don't put it back.
okay, yeah. Okay, and the took, yeah, the previous Kaohsiung's the fellow.
Oh, yeah.
Yeah. He asking, have
You
you
too.
ever combined the cancers with the bone block?
In my very early career, I have done that before because I have a lot of problem to have a successful alveolar bone grafting, and I found the nasal floor wound is very easy to be broken, and I found a paper. The doctor from Norway or somewhere, he used a bone block to protect the nasal site and then the cancerous bone on the alveolar cleft. I have done once, but I used the wire to fix it, the bone block. I found it's not really a good thing. So finally, I didn't do that again.
Okay, and the next question from Dr. Ruby. I think it's the same question from mine. Yeah, sometimes we also struggle to close the nasal mucosa of the quite big anterior fistula. So what is your tip? What is your suggestion? Thank you.
I think the buccal side, when I dissect the buccal side from the nasal floor, oh, I have to say, because I have a very wide dissection, so it's not difficult to separate the buccal mucosa from the nasal floor. And I dissect the nasal mucosa and the periosteum from the piriformis aperture widely. So it's very easy to close the nasal side at this part. I mean the anterior part, the nasal floor. It's easy. I think the most difficult part is the deep part. I call it the apex because I think the alveolar cleft is like a pyramidal form. So the apex part is the most difficult part. And if the alveolar cleft is narrow, it's very difficult to suture it. And very wide cleft, of course, is easy to handle your needle holder or your needle, but it's a big cleft. So that's why in some cases I need Professor Law's technique, use the fascia graft to cover the deepest part. I think it's a good way to solve this problem. I hope you can do that. Yeah, maybe can get a good result.
Okay. Do you do the orthodontic treatment before ABG, such as maxillary expansion or something?
Yes. Actually, our orthodontists are very experienced doctor. They will see, and we will decide the timing if they think the maxillary expansion is necessary, and we will see. I think the question of the other side is that if we do the maxillary expansion, sometimes we have a wider alveolar cleft, and some people think it will compromise the success of the alveolar bone grafting. I think maybe it's not the story. I think if we really necessary to expand it, we expand it.
Okay, the next question is please explain how you avoid the gag problems, 张口气 on the palate in order to repair the alveolus during a palatal repair.
Oh, I use one side.
Uh-huh.
One side prong.
Okay.
I don't know. Maybe I don't know. I don't find it's a problem. Sometimes I will use the tongue depressor only, and of course I need an assistant to hold the tongue depressor for me, so I can have enough space to do the manipulation.
Okay, from Dex, for adult ABG patient, how soon after the operation will you ask the orthodontist to start movement? And do you have special instruction for the orthodontics? Thank you.
Well, I will let our orthodontic decide, but of course we have to make sure the wound heal well, and of course the bone will heal in a couple of weeks, and some doctor will say that is the early movement of the tooth by the orthodontic into the alveolar bone graft is a good thing, but that depends on our orthodontic. They will decide it.
Yeah, I saw the orthodontic Dr. Michael Chang is online here also. All right. Our next questions, yes. Regarding to removal of deciduous tooth, what is the difference between removing before and during operation? And at least how long deciduous tooth need to be removed before operation?
Yes, a very practical question. And I told it during the presentation. First, if the patient can tolerate the extraction, please extract it before the surgery. And at least 1 month, or maybe 2 months before or 3 months before, I think it's all right. And if I extract the tooth during the operation, I have to make sure I can close the wound. Well, usually it's okay if I can advance the gingival mucoperiosteum flap a lot. It's okay. But as I say, if possible, please extract the tooth beforehand.
Okay. Okay. Would you suggest to fracture the premaxilla in bilateral case so that it can be easier to suture the palatal site?
Well, actually, I have done several cases like this way. We call it the setback the premaxilla, and I didn't show these cases in this presentation. Yeah, in some very special situation, we can did the segmental osteotomy of the premaxilla over the vomer bone, and then use wire or a pin to fix it the premaxilla. And I usually do one side of the bone grafting at the same time, and then do the other side bone grafting a couple months later. In those cases, most of them have successful alveolar bone grafting, but always as the midface hypoplasia retrusion. And I even failed in one case. So we have to do this kind of procedure carefully in selected patient.
Okay. If an adult cleft patient did not have bone graft before, what kind of bone graft do you use for implantation?
Usually I will use the such as the mandible angle. If we do the setback of the mandible, sometimes we have bone, the cortical bone from the mandible angle on the body. We can use that. If the cleft is if the defect is big, I will use the iliac crest with the block and the cancerous bone together. In very few situations, I will choose the Hawaiian bone graft.
Okay. Professor, can we use allograft only for APG? And how is the prognosis?
Good question. Up to now, some studies show, I have shown some paper on the presentation. Yes, the most convincing is the DBM plus the recombinant human BMP2 protein. Yes, some studies say that it's enough to get a successful repair of the alveolar cleft. In my practice, I have some cases use the very small amount of cancerous bone from the mandible plus some bone substitute. Here we have some calcium sulfate. We can put it together and do the alveolar bone grafting. And the result is also good. And I mentioned it in these small population, the alveolar bone grafting seems thinner, not as high or as big as the second. Use the iliac crest cancerous bone.
In your opinion, which is your favorite donor site? And when you harvest the bone from the mandible, which is your best choice between the chin and the mandible angle? Yeah, because you're considering the OGS in the future. Yeah.
Oh yeah, for the young children, I use the paracentesis. Yeah, and I know some study they use the anterior part of the angle. It's not angle. It's just the anterior part of the ramus. Yeah, I remember it also published. It's come from the Lincoln, right?
I'm not sure. Okay.
Yeah, it seems that Dr. Lin.
Okay, I will check. Yeah. Our next question is the oral hygiene, arch formation, teeth alignment, but we do not have distraction osteogenesis. So how could we fix in severe cases?
Sitong, can you explain more detail? You mean without distraction, what we can do?
Yeah. Yes.
Okay. Yeah. If you really need to do the alveolar grafting, you can think about the setback of the premaxilla. Okay. Yeah, I think that will be a little bit easier. And then later on, we will do the OGS to solve the problem.
Okay. Two more questions. Yeah, I hope we can satisfy all the audience in the webinar. So two more questions. Yes, thank you, Professor Lai. In a case with palatal dehiscence post palatoplasty few years ago, could I do ABG procedure at the same time with palatal revision?
Wow. I think it depends on the local situation. I suggest that you can elevate the palatal flap first. And if you can close the fistula with this palatal flap, and then you go on to harvest the cancerous bone graft, and then do the bone grafting at the same time. If the closure of the palatal side fistula is not so secure, I suggest you close the fistula first. And maybe that wound all healed, and you do the alveolar bone grafting. I think they would be safer. I'm a conservative man, so I always think safe way.
Okay, the last questions from Dr. Osaguana. Professors, in some cases, the nasal mucosa may have to be incised so that you can create a proper seal for nasal closure and the palatal closure. He learned this method from Professor Philip Chang. Do you do this, Professor Lai?
Let me check. The nasal mucosa may have to be incised so that you can create a proper seal. Oh, yes. If you see from the movie, yes, I will trim some soft tissue, but be careful. Don't take too much out, or you will become a problem. This closure will become with high tension. There will be a strategy.
Okay. So I think that all the questions already be answered. And then currently I want to invite some our expertise. You guys are showing your face to me. So probably you can give some comment to Professor Lai's presentation today. The first one, I think Dr. Professor Clementine, how are you? You can say hello to Professor Lai.
Actually, I am not really an expert, but since I was a resident, I have done some ABG for our senior doctors. And I always have one question that should I crush the cancerous bone graft or not, or just put in the space piece by piece?
Well, usually I will cut it, not crush it. Use the cutter, cut into small pieces. It's easier to fit the defect. That's only meaning. I don't think right now I don't squeeze the cancerous bone into the defect artery. I just insert it. Okay.
Okay.
Yes, it's a nice way.
Thank you, Dr. Lin. Professor Frank Chen, in Professor Lai's presentation, he cited you one of your best paper here. Do you have any comment for Professor Lai's presentation? Thank you.
Yes, Xin.
Yes, Professor Lai, thank you for excellent education lecture. Myself, I have much less experience compared with you, but I totally agree that the second bone grafting, the mixed dentition, we read your paper as well as other paper all show minimal or no face growth disturbance. And we will agree pre-ABG also treatment because it will increase the bone graft volume. And we also use iliac bone as our preferred donor site. And as you mentioned, when we dissect deep inside, when it's difficult to close, we use scapa fascia as Dr. Lowe's technique to close it. The only one question I raise is the really overgrafting needed. Before Bang Yun's publication on Journal Clinical Medicine 2019 showed that 1.09 millimeter of bone defect. I put almost more than 3 cc. I put almost 8 cc, you know. It's all bulging, you know. When I close the wound, there are still some bone graft bulging out the wound. And when I look back and evaluate the CT, all the overgraft bone have been resorbed. So currently, I just put adequate bone graft. But I know we need more study to evaluate if really adequate bone graft and the over bone grafting has the same result. That's the only question I raised. Thank you.
Yeah, yeah. Thank you for your comment. And actually, that's the my last slide said. If we want to do the implant surgery into the alveolar cleft site, you know, the bone graft, the request of the volume of the bone is quite a lot. It cannot just well, now we evaluate the height of the alveolar bone graft. So there will be another issue, I think. The bone graft inside the alveolar cleft should be thick enough, high enough to contain the implant screw, or we cannot have the implant surgery inside the alveolar cleft. I think there will be another issue. You will see.
Okay, thank you. Thank you. And now I want to invite Professor Lunzhou Lou to give us a master's talk with the Professor Lai. Please.
Hi everyone. First of all, I would like to thank Dr. Lai for his good presentation about the alveolar bone graft. And in my mind, I think that alveolar bone graft is one of the most difficult operation in cleft surgery. So we really have to be very carefully when we perform the surgery. As Professor Lai mentioned that he described his learning curve in the beginning. A lot of cases fail, and maybe he has to do a secondary bone graft. So when we, all of you, when you perform the bone graft, please be very careful. Dissect the tissue, carefully close the nasal floor and palatal mucosa. And then if you could not close the most deep pocket, you may use the scapa fascia to cover the posterior part. I myself routinely use scapa fascia. And also remember that closure, the oral mucosa flap should be under minimal tension. And also when you suture the flap, close the wound, gingiva is a good tissue that you can closely tight your suture. But when it comes to the mucosa, please very snugly close the wound. So if the wound is closed under minimal tension, you may expect that the wound healing could be nice. Otherwise, you see some opening of the mucosa wound. and then you will see the chronic wound and difficult healing, and also bone resorption. With regard to the bone cancerous bone volume, certainly to me, I believe that the defect is quite small. We don't need to put the bone graft deep inside, but it's up to you, because to me, the alveolar bone graft, the purpose is to maintain the arch continuity, and then to provide the bone to facilitate the eruption of the tooth root, especially canine. So to me, my concept is no need to put bone graft into the back part, the posterior part. And certainly, if you have more bone, you put it in the posterior part, you can establish the stability between the two bone segments. But again, I think the alveolar bone graft still technically is still controversial. Many people have his own idea, but I appreciate Professor Lai that he very carefully and very widely described the aspect of alveolar bone graft. Thank you, Dr. Lai.
Thank you for your recommendation.
Okay, thank you, Professor Lai. Thank you, Professor Low. I will invite all the audience, if you are still awake or you are still on the line with us, you can turn on your screen. Hello, Dr. Honda. Hello, Dr. Nen, Dr. Tim Sam. Your son is so cute. Yeah, Dr. Saka, how are you? Hi, Sato from Japan. How are you? Hello, Dr. Q, Dr. Beer. All right. Thank you, Dr. Nikolova. Yes. Okay, I think it's time to click my camera now. So, hello. I will count to 3 and please show you a smile. 1, 2, cheese. Perfect. Let's go on to the next page. Okay, please. 1, 2, cheese. Okay, thank you. Yeah, thank you very much for your participation today for Professor Lai's presentation. I hope I can satisfy all your requirements and all your questions. And I hope that Dr. Lai will enjoy this presentation as well. I will introduce our next webinar in ICC. 2 weeks later, the Professor Fayyaz from Pakistan will give us a presentation. And his presentation, the topic will focus on the palatal fistula. The topic is the Pakistan Comprehensive Fistula Classification and the Management of Palatal Fistula. And still looking forward to your participation and for your support. Okay, thank you all my friends, and thank you for the friends from our neighbor countries, no matter where you are or no matter where you already meet for Professor Lai. Yeah, because of COVID, we could not attend to your country for to join your party, the missions. I hope that one day we will meet you in person. Thank you for your coming.
Thank you.
See you.
Everybody.
Bye.
Thank you. Thank you,
Bye.
Professor Low. Goodbye.
Bye-bye.